skin. Chapter 33. Let's get crack-a-lacking. Okay, anatomy and physiology, please. I don't need to go through this. Make sure you know the different structures of the skin and what the purpose they serve. Epidermis, dermis, and subcutaneous. You need to know this for several reasons. Number one, for wound care. You also need it for medication administration, for example. So make sure you know the different layers as it relates to the skin and what purpose they serve and what happens potentially if they are destroyed. Now, also know the function of the skin. And the skin is, we already know, is the smallest organ of the body, correct? Oh, yes, should be saying what? So it's what? Okay, just making sure. Okay, Alana actually had reason to give me that look. Like, what the hell are you talking about, bro? You sipping on something? Okay, so it's the largest organ of the body, and you must know what are the functions of the skin: sensation, vitamin D production. It helps with the immune system, etc. All right. Now, these are the different anatomies as it relates to the skin. You have your epidermis, your hair follicle, etc. Not going into that. Now, when it comes to the integrity of the skin, you need to know the factors that affects its integrity. When a skin is said to be unbroken or basically intact, and healthy, it can definitely do its job and defend against harmful agents. Resistance to injury is affected by age, of course, because just like every other body system, as you age, your body tends to decline. And your resistance is also affected by the amount of underlying tissue. So if you got too much underlying tissue, are you protected or not protected so much? Juliana, what sayest thou?
Well, I don't know. I mean, I know in animals, if they have more underlying tissue, they're more protected.
But human beings, such as you and I.
I mean, yeah.
Okay, she said, so Krista said are you saying you more protected when you have an extra cushion?
I mean, my butt is. Floor a little bit longer than people who don't have any extra cushion.
Okay, so then can you have too much or too little extra cushion?
Yeah.
Yes. Okay. And that part, in terms of the amount of underlying tissues, we're going to find out where, especially in certain parts, like you mentioned, like the sacral area, where you're going, if you don't have enough cushioning, like Crystal says, we might be in trouble, okay? And also resistance to injury is also affected by the injury, okay? So, of course, illness. If I suffer from cancer, for example, all right, my resistance to injury is further compromised, all right? Nutrients, nourishment. If you are poorly nourished, your skin will be in trouble if you're not getting adequate nutrients. I know we're not there yet, but what nutrients definitely play a role in the skin? Protein. What's another nutrient besides protein? Water. Say it again. Vitamin C, zinc. All of these things you are looking at to see if the patient, to see if their skin could be healing properly, and if it's not healing properly, maybe it's because of these inadequate nutrients, okay? And of course, adequate circulation is necessary to maintain cellular life. All right, we already know the developmental consideration. We're gonna skip the little people for now. You'll get them in third semester when you see me, all right? But when it comes to the adults and older adults, the structure of the skin changes as a person ages. The maturation of epidermal cells is prolonged, leading to thin, easily damaged skin. So when you get these older people, for example, you got to be very gentle how you handle them, because their skin is naturally thinner. Not just the older adults, but also people who suffer from certain disease processes. For example, if you have renal patients, okay, those who suffer chronic liver disease, their skin is usually paper thin and very fragile. So you can't be manhandling them. Okay, let me not say that, but you can't be dealing them normally as you would a regular patient who has no skin integrity. You might have to be a little bit more delicate. Okay, let's say, for example, when we do wound care, the adhesive that you apply, you may actually not use the same adhesive that you would on a person who has an intact skin or a thicker skin in terms of thickness. Instead, you might use a more the paper tape. So instead of using a tape such as this, the surgical tape like this, you might use a paper tape to perform wound care, for example. All right. So those things you have to take into consideration. All right. And then, like it says, for the ulcers, the other thing is circulation and collagen formation are also impaired. And we know we need good collagen for good skin, right? Or a good amount of collagen, all right? So we're looking at those factors as well. Now, causes of skin alteration, having very thin skin, being obese, okay, or morbidly obese, they are susceptible to skin injury. So this is why those who have let's go with the obesity. You're going to look at the skin folds. You have to look at the underneath the skin folds, because you can see they're most likely prone to skin impairment. They might have redness, fissures, etc. Right? Fluid loss during certain illnesses that leads to dehydration can also predispose an individual to skin breakdown. Again, if you're not getting enough fluid, you are prone to skin impairment. Jaundice, and we already know what jaundice means again. What is jaundice? Okay, all right, just making sure y'all still here. Diseases of the skin, such as eczema and psoriasis, also can cause skin lesion, okay? And because of that, your care is going to be different. You got to know this so you know how to implement care and provide adequate care as well. Now, what page is this on? The different types of wounds. You see the different types of wounds? Wound classification starting on page 1154 in your book. Do not play with me, okay, on the different types of wounds. Because you cannot go throughout the rest of the program not knowing the different types of wound. And you better not go into NCLEX, and more importantly, into the nursing profession not knowing the different types of wound, because it doesn't matter really what unit you're working in, you're going to be dealing with the skin nonetheless. So you have intentional and unintentional wound. Very basic. Bree, what is intentional wound? What is intentional? Huh?
Like purposely.
Yeah, I cut you on purpose. Okay, now when they say I cut you on purpose, Juliana's not what you think. I ain't trying to hurt you. It's not for the purpose of hurting you. It's for the purpose of healing you. We created this wound. So hence surgery. That's an intentional wound. Right, because you gotta get cut. Or when you do something simple like inserting a peripheral IV, isn't the wound broken? You just caused the wound break, sort of a wound break. You just broke the skin. Like when you do the peripheral IV, right? You already impaired the skin. That's intentional, all for the purpose of healing. Okay. However, there is unintentional wounds. That is just trauma to the body, okay? Like maybe a motor vehicle accident, you fell down a ladder, for example, and now you got a skin break, you're bleeding, etc. All right? So those are two main types of wounds. Then you have the neuropathic or vascular wound. You also have, pressure-related, open or closed, acute, and partial thickness. Now, the main one I really want to look at, pressure-related wounds. What do they mean by that, Liana? Okay, so you staying in that one position for an extended period of time, and now your skin is impaired. Hence, what you do. Oh, I think you mentioned something very important. What you said?
Bony prominence.
What about bony prominence? What about those?
They're not, if they're turned only on one side for a long period of time, or they're just not turning at all.
So in other words, those bony prominences, like you mentioned, the hips, the bony parts of your body, they're more prone to skin breakdown. This is why turning the patient frequently, at least every 2 hours, is very important. or putting like different using, for example, specialty beds, or sometimes you may put a pillow underneath that bony prominent area just to relieve pressure off of that particular area. Okay, hence pressure related wounds. Then you have wounds that are either open or closed, and you do have and it's discussed on page 1154, and the open wound occurs from an intentional or unintentional trauma because it's open, and then you have the closed wound, which results from like a blow force, for example. Okay, so in other words, the patient has a wound, but you don't see it's broken. You do not see the skin is broken or open. Okay. Now, you also have a matter of when it comes to partial thickness, full thickness, and complex thickness or complex wounds, in other words. All right. When they say partial thickness, Rebecca, what does that mean? Sure, yeah.
Can you repeat that, please?
Partial thickness, ¿qué es eso? What is that?
Is intact.
Okay, say it again. Thank you, Lifeline. Say it again.
Where all or a portion of the dermis is intact.
So all or a portion of the dermis is intact. Plain English. I don't understand what you just said. I did not understand the words that are coming out of your mouth. So can you please explain what you mean by that? Yeah. Your Lifeline helped you find the answer. Now help you explain the answer.
Like the skin is intact.
When they say the skin is intact, what is that? I'm the 4 and 2-year-old who just got off the boat the other day. I don't know what intact means.
Repeat the question.
What does partial? She said, or she explained what partial thickness wound is, and she said when part of the wound is intact. That's what she said to me.
That's what she said.
Oh, what did you say? Huh? When a part of the skin, your bad, is intact. All or part of the skin is intact. What does that mean?
It's not broken.
Thank you, Lifeline. Juliana, what says thou?
I don't know, I was just gonna say like, this is like commonly used like burn, like to describe burn.
It could describe to burn, yes.
Like really only the top layer. If any, only the top layer of the dermis is affected.
Okay, so it's basically the layer in which the depth in which the wound, your skin, is altered. Does that make sense?
So it's not intact.
Yes. So with partial thickness wound, which is very important, I want you to make sure you understand that could mean your skin is intact. In other words, it's not broken. But if your skin ain't broken, then how come it's a wound then? Yes, Crystal.
So it says that non-blanchable is when the skin partial thickness, the top layer is exposed to dermis.
So what does that mean, non-blanchable? What page are you on?
1165.
Okay. When they say non-blanchable, in terms of what does that mean?
It means that the skin is still the skin layer is not broken, but underneath there's damage.
Okay, how can I assess for that? Do you know how to assess for a blanch or non-blanchable skin?
Like
you press the area, if it doesn't
Look, you can do that right now.
if it doesn't turn white.
Yes, look at your skin. You do this, boom. You see how it turns white? It's blanched. That's what you're looking for. What you looking for? We got what you. Okay, anyway. All right. You see how when you press your skin, what is it? It turns white and then it goes back to its normal color. But somebody whose skin is not intact, you won't see that happening. Hence why it's a partial. It falls under partial thickness because the skin is not broken, but yet it's non-blanchable. Does that make sense? That's why it falls under, it can't fall under partial thickness, right? Then you have full, and we'll go into the primary, second, the layers, okay? Full thickness is what? What is full thickness? Well, if partial thickness is part or none of the skin is intact. What is full thickness then?
Deeper one.
There, so is the skin intact at this point? No. Now the skin is definitely not intact. Okay, it's not deeper than a blanchable versus non-blanchable. You ain't gonna get no blanch for sure. But let's go to the pressure stages real quick on 1165. Okay, which basically talks about the levels of pressure injury. All right, if you look at stage 1, okay, the pressure injury, what you notice, you have the non-blanchable, you also have redness, but the skin is still intact. Okay, so this top layer is cool. With stage 1, that is stage 1. Your skin is still unbroken. It's not intact, but it's not broken. Okay, but you just don't have the blanch. Okay, now but there is pressure injury. If you notice what's happening with stage 2, what does it say is happening with stage 2? Now the skin is what? At the stage 2. You have the partial, but you have skin loss. Okay? And the skin is lost to what layer of skin? Okay, so your not your subcutaneous, your epidermis is no longer intact, right? Because the epidermis is the top layer, right? So it's now down to the dermis, where you have up to the dermis where your skin is no longer intact or broken, right? Y'all see that? And then when you go to stage 3, now how deep is the wound? Down to where? Huh? The fat, subcutaneous. Is that subcutaneous?
Adipose.
Yes, right? Adipose. Okay. Do y'all see that? And then stage 4 is basically down to where? Down to the bones. You can see the bone being exposed in terms of wound injury, pressure injury. Do y'all see that? Stage 4, full thickness skin and issue loss with exposed or directly palpable fascia, muscles, tendons, ligaments, cartilage, or even the bone in the wound, or here they say the ulcer. Also, what you see with stage 4, there could be sloughing and also eschar. What is slough? I don't know what that is.
Isn't eschar unstageable?
It can be, but what is slough first before we get to eschar? What is sloughing?
That's when you like scraping.
Clotting tissue. It cut what? Huh?
What did you say?
Slough. What is that?
Oh, when the skin comes off.
Okay. What now? What is eschar? I have no idea what is that. What is that either?
Necrotic
Huh?
tissue.
It could be necrotic tissue, and that's where it's exposed. Now the thing is, with stage 4, they're exposed. However, another stage is also unstageable. Okay, now you see with the unstageable pressure injury what happened. This is a full thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because it's obscured by sloughing or eschar. That necrotic tissue, the necrosis, the sloughing and stuff like that basically is blocking the depth of the wound. Hence, that's why they call it unstageable. Are we cool? So stage 1, pressure injury, the damage is done to what layer? Okay, well, sometimes, well, what happens with the stage 1? It's not broken, it's non-blanchable. Stage 2,
Well, it's broken.
well, what? Come tell me, Crystal.
You asked what layer does the damage happen? In stage 1, there's damage to the other layers, it's just not exposed yet.
It's just not exposed. Okay, so exposure is not to, it's just no exposure, okay? Right? That's true. That is actually true. Stage 2, now damage is to what layer? Up to, so the epidermis is broken. You can see the dermis, etc. Okay, don't play with me. And notice the characteristics of the wound bed that they give you: viable, pink or red, moist, may also present as intact or ruptured serum blisters. That's another one that gets students. I need you to highlight that. The blister. This is on 1165. On stage 2.
And what is a serum filled blister exactly?
Oh, fluid, like pus. Like serious, like the fluid that you get from. Yeah. Okay.
Oh, this one? Yeah. Okay, thank you.
All right. Because this is another thing that students tend to miss, and I don't want you to miss it, and I don't want you to say, "Well, Dr. Hammy," and this is your review. All right. And notice what happens again. The wound is viable, pink or red, moist, and then and may also present as an intact or ruptured serum filled blister. You get a blister, that is stage 2. You get a blister, stage 2, according to this book. All right, blah blah blah. All right, and then stage 3, you got full thickness, where now the adipose tissue is exposed. You may have granulation, sloughing and eschar may be visible at this time, not always. But you see, it's basically skin loss down to the adipose tissue. All right, and then stage 4, it can go down to the ligaments and bones and cartilage as well. And this is where you, again, may or may not see sloughing and eschar. And make sure you know with the unstageable what happens. You have eschar, you have sloughing, but they just cop blocking. They just don't let you see how deep the wound is. It's like they're hiding. Okay, cop. I know my bad. They're just oh man, let me say the proper word. My bad. They are hiding in secret the depth of the wound. Rebecca, don't judge me. Leave me alone. Rebecca's like, because you don't see how deep the wound is, so they're hiding the. Okay. You know what? Just go with the flow. I was on a roll for a minute. Okay. All right. It was working.
I'm ready.
Okay.
What? Leave me alone.
Listen, the next time I hear the word cock blocking, this is all I'm going to say.
The unstageable.
Me from doing anything with anybody.
Can you see anything? They're hiding. Just like a big old security guard is keeping you from going into the club, because you ain't got access. So that's what the slough and eschar is doing. They're blocking you from entering to see what's going on inside.
Okay.
Tell me that didn't make sense. I didn't know. It made
No entry allowed.
No entry allowed. You can't view to see what's going on.
Chastity belt.
Oh my god.
No, you must not.
Oh Lord, let's keep going. Oh, before I move forward, let me go backwards. Let me go backwards a little bit. I want you to make sure you know, is this here? Okay, that's what this is. The type of wound, 1155. Do not play with me with these charts and boxes, okay? You've been warned. Know your different types of wound. You got your incision, which is basically a cut, okay? Or a cut, okay, for the most part. And it's approximated. For example, you have your contusion, which is done with a blunt instrument, but the overlying skin remains intact. You have an abrasion caused by friction, laceration, which is basically tearing of the skin. So make sure you know your terminologies. And yeah, I said terminologies. Leave me alone, okay?
Laceration is tearing of the skin?
That's what it's right there, 1155.
What does it say avulsion is?
Avulsion is tearing a structure from normal anatomic position.
Okay.
It's right there. You see it there? You don't have your book. Okay. All right. It's there. Okay. So on and so forth. Make sure also don't play with me with the different types of ulcers also listed on that table. You got your pressure ulcers, which Leanna explained to you what could happen, which is basically due to compromised circulation. Your venous ulcers is because you got poor venous return or injury as a result. And then arterial, okay, you have ischemia due to a lack of blood flow to that extremity. And then you also have your diabetic ulcers, which forms as a result of diabetic neuropathy. And again, what is diabetic neuropathy or neuropathy? What is neuropathy?
Losing a feeling.
Losing feeling. Okay, let me stop right here.
Is it losing feeling or is it losing function of those nerves?
It could actually be both, but you first do lose feelings, right? Now, let me ask you, if a person has diabetic neuropathy, right, where why I say it could be both, it depends on the extent, right, of the neuropathy. But definitely what you do lose first is your feelings. Now, if you know your patient has diabetic neuropathy, say it louder.
Feet.
What about your feet?
You gotta stretch them.
Okay. Why not go barefoot?
You can't tell if you get hurt.
You can't tell if you got hurt. It has been. It's still common to this day. Okay, where patients come to the ER and they just came because their foot all of a sudden became black, or their toe is chopped off. If I had time, I should have put that episode on Resident where this man came into the ER and his toe, all you had to do was like this. Yeah. Yes. Okay. It was cool. I was like, oh, look at that. Okay.
What happened?
He came and his toe was literally, the big toe was literally hanging off his foot.
Oh.
Yeah, and he didn't feel nothing. He was like, you know, all that. Yeah. Okay. So again, they have to make sure they wear protective shoes or footwear. Check your feet periodically. And also the other thing too, with regards to diabetic neuropathy or neuropathy generally speaking, like to maintain safety, another thing you may want to consider is the water temperature. Okay, so they can't tell when the water is too hot. So you are the one that has to make sure you do the assess the warmth of that water. For example, that's a part of safety. Yes, Crystal.
Yeah, man, I forgot what I was gonna ask.
Okay. Okay.
Sometimes they also have pain, like on the bottom of their feet, like.
So if they have pain, that's actually kind of a good sign. That means there's still some the nerve is still working. But sometimes they may not even have pain ever. Well, I shouldn't say ever, but well, yeah, depending on how bad they might have never get pain and feeling, and that includes pain. All right. Principles of wound healing. Make sure you are familiar with how the wound heals, starting on page 1155. How the wounds healed is the intact skin is the first line of defense. Careful hand hygiene is used in caring for a wound. Okay? Do not play with me. Wash your hands. But when you wash your hands, Alana, what water temperature are you going to be washing your hands with? Okay, it don't gotta be cold, okay?
Not burning.
Yeah, not burning hot, okay? Room temperature water at least, okay? Girl, don't be doing that face. I already know hot water it is, huh? Yeah, you and I both. I'm still, listen.
Yeah, I think they said when you take a shower, it should be with cold water, not hot.
It should, but not me, okay? Not me. But what education are you gonna provide me with since I still shower? I come to you and I tell you I still shower with very hot water because it feels good. What you gonna do?
Your pores.
Yeah.
Huh?
Your pores and how it opens up and then it causes dirt and what else?
Risk of infection. So, but I love my little hot water. What am I gonna do? What are you gonna educate me to do then? How about
Make it warm.
maybe, but maybe finish off with cold water. Maybe. Yeah, I don't know about that one. But it is what it is, okay? So careful hand hygiene. The body responds systematically to the trauma of any of its parts. Again, just remember, Sully, the body's always trying to stay alive, okay? An adequate blood supply is very important for normal body response to injury, and normal healing is promoted when the wound is free of foreign material. So this is why when you do it, if the person got a cut, this is why you're trying to make sure you cleanse that site as much as possible, okay, using the appropriate solution. Typically, it's normal saline that they use, 0.9% normal saline, again, that they use typically. to cleanse the wounds, okay? The extent of damage and a person's state of health does affect how well the wound is going to be healing. So again, if the patient has certain disease processes that they're enduring, for example, renal disease or maybe cancer, for example, that can affect how well the wound is going to heal, especially diabetes is another one too, because some of these wounds, if the patient is diabetic, it's going to be harder for that wound to heal, all right? Response to wounds is more effective if proper nutrition is maintained. And what nutrition, again, are we concerned that the patient maintains? Protein. Okay, let's stop right there for a minute. Okay, all right. How will I know that the patient is consuming adequate amount of protein? I love your pronunciation, girl, because you're making me look good. How you call it? How you pronounce it, girl? Now she don't want to pronounce it. What are we looking at?
BMI.
We actually could look at BMI. We could, but the lab, one of them going to look at, she said BMI is not a bad response, but we're also looking at the lab's albumin. Okay, and your book does go into the what is the albumin level somewhere later on in this chapter. All right. In addition to albumin, which tells you your especially how much protein and proper nutrient that the patient is consuming, albumin levels, you're also going to look at a more sensitive indicator, which is known as pre-albumin. That's another lab you are going to look at. Because if it's not enough or inadequate, again, that is going to lead to improper wound healing.
What is that again?
Pre-albumin.
So it's what did you say? It's measured.
If it's not enough, then that can lead to improper wound healing. Okay? Another nutrient that you're gonna look okay, we said protein. What's another nutrient? I mentioned some of them. Collagen. We want to make sure.
Vitamins, minerals.
Okay, vitamins and minerals, definitely. Zinc is another. All of that. Do not play with me. So proper nutrients is maintained. So you got a patient who got an extensive wound. These are some of the things that you may want to consider is their nutritional status. Okay? Well, hold on, Sophie. Also, you may want to make referral to a, oh my gosh, they don't call it nutritionist. Is that what it's called? Dietary. Okay, nutritionist, I think it's called. Okay, they have to be on site. Okay, because you have to make sure, they will make sure if the patient is getting adequate nutrition. Nutritionist, I don't know why I'm tripping. Sophie.
What do you also do a coagulation panel?
Oh, why would I look at a coagulation panel for wound healing?
Because if you can't clot, you're not going to be able to heal certain wounds.
Ooh. Okay, do you have an idea which wounds?
Any that extend into the dermis.
Okay, you're absolutely correct. Yes, coagulability does play a role. Okay.
Oh, here it is. Page 1174.
1174.
Has albumin levels. Pre-albumin. Length of average.
On page 1174. Oh, you see? Y'all what y'all notice? Numbers. Don't play with me. So now I am free to decide whether or not if I'm going to provide a reference range or not. Don't play with me, Nate. There goes your review. Boom. Okay. You see?
No.
Make sure real quick, you know the phases of your wound. Hemostasis, inflammatory, proliferation, maturation. You should have an idea what the wound stages are. Okay, hemostasis, basically, this is what happens right after the initial wound. And then with hemostasis, you have exudation being formed, increased perfusion. And this is where you have stimulation of platelets, okay, that migrates to where that injury took place. This is all happening at the hemostasis phase. Then at the inflammatory phase, after the hemostasis, which can last about 2 to 3 days, you have an increase in white counts, okay, moving towards the wound. And this is where you have all that microphases and all that stuff taking place. Also, there's an accumulation of exudate causing pain, redness, and swelling. And this is where the patient has a generalized body response. In other words, not just at the wound site, but they're starting to feel it, the effects of the wound generally throughout their entire body, all right? At the proliferation phase, this can last for weeks. Now, all of this does depend on the extent of the wound. Because some wounds, they'll be healed within hours. Other wounds, it might be healed within months to years, okay, depending on the extent of the wound. But proliferation phases last for several weeks, and new tissue is built to fill the wound space through the action of this thing called fibroblast, all right? And this is where the main thing I want you to get from here at the proliferative phase, granulation tissue forms as a foundation so that you're going to start to see scar tissue taking place, right? That's at the proliferation phase. And when the wound begins, I just like to call it mature. The maturity phase, okay, I don't know if it's appropriate, but the maturation phase, this is the final stage of healing, which can begin about 3 weeks after injury. Again, it can take up to years for a wound to reach maturation phase. Now, remember, it depends on the extent of the wound, all right? Here at the maturation phase, we're becoming mature and collagen is being remodeled, new collagen is being formed, and you have the formation of the scar. Now, some people may scar. Most people will scar depending, again, the depth of the wound, but with the scar, it's usually a flat, thin, white, a line where you have a lack of sweat where due to avascularization, there may not be any hair growth or they may tan. See, like me, right here, little, I guess, a little scar right here, which they call a keloid. All right, now, local factors, again, affecting the wound, which we talked about. And don't play with me on these factors because you must know these, okay? Right here. You have pressure. We talked about the pressure. I do not need to beat a dead horse with regards to the pressure. However, you must make sure you are familiar with the term desiccation. You see, I took my time to pronounce that correctly so y'all don't play with me. Okay? And it's only because I could pronounce it well anyway. But desiccation, this has to do with dehydration. It's not a lot of moisture going on here. Okay? With maceration, there's an issue of overhydration. Y'all see that? Whoever got it, please.
57.
Thank you. Okay? Make sure you are familiar with those terms. Okay? Then you have trauma, which is pretty much self-explanatory. All right? You also have edema, which is swelling, infection. Y'all know infection. Excessive bleeding, necrosis, which is tissue death, which you must be very familiar with in terms of knowing that term. And then you need to know, no, it's not, is it listed here? Biofilm? Yeah, biofilm is there, okay? Which is basically a grouping of microorganisms, all right? There's also circulation and oxygenation. So because you do need adequate circulation and oxygenation for proper wound healing, one of your assessments may include oxygen saturation. Okay, it may be included. All right. All right. Now, we need to know the factors that affect wound healing. You already know the age. And again, I'm not going to test you on the children, but you do need to know one of the factors is as you get older, especially if you're a healthy adult, your wound healing will most likely take place quicker versus an unhealthy adult or even older adult. Circulation and oxygenation, I talked about. Nutritional status, which we talked about. Do not play with me with the albumin and prealbumin. What is the cause of the wound? In terms of wound etiology, basically means the cause of the wound, okay? Specific conditions of the wound that affects wound healing. Your health status, what drugs you on, okay? The drugs that you on, some of the drugs that a client may be on may affect wound healing. For example, corticosteroid drugs. If you are on corticosteroid drugs, that may delay wound healing. Now, if a patient is on steroid drugs and they have an extensive wound that needs to be healed, the physicians, the healthcare providers are going to weigh the risk versus the benefits of continuing or discontinuing their steroid medication. And remember, with steroids, it has to be tapered down. You can't just stop them abruptly. It don't matter what steroid you got. Okay, you're on. Okay. What else? Immune suppression. You already know if your immune system is compromised and your skin is your best immune defense, if that's compromised, that's also going to delay wound healing as well. Adherence to treatment plan. Now, with regards to adherence to treatment plans, I'm going to come back to medication. Guys, remember, you have to assess in detail why the person is non-adherent. Not all clients are non-adherent because they don't want to follow the prescription. Some of them are non-adherent because of, again, socio-demographic issues, socioeconomic issues, or whatnot. So their pockets may not be right. Or maybe because they don't understand. There's a lack of understanding. So do not just write the person off as being non-compliant or they just difficult or whatever. Assess why are they non-adherent. We're not supposed to say non-compliant, I guess. All right. Now, with regards to med use, because you legal drug dealers now, okay? On page 1159, they give you a whole list of medications besides steroids. You got chemo drugs, okay? Prolonged antibiotic therapy increases a patient's risk for secondary infection and super infection. Prolonged. So in other words, that means if your client is on antibiotic, you're trying to see how long have they been on this specifically antibiotic therapy, and if it can be I don't want to say discontinued. Yeah, if it can be stopped.
At what point is it considered prolonged?
Ooh, it depends. Usually, for example, it depends on the medication and the illness, right? So let's say, for example, if you had like ear infection, typically they can be given something like maybe Augmentin, which is given over maybe 7 to 10 days. But if you want it for like 30 days, 2 months on the same Augmentin, something's not right.
So is it prolonged in relation to like the usual course for that?
Yes.
Okay.
Yes. And it could be also because of maybe the doctor wanted to continue the regimen, maybe because there's still that bug living in the client. So instead of changing it, they maintain that same medication. Now, the problem is the risk of developing a super infection. Also, sometimes poor therapy, poor treatment choice. What do I mean by that? So remember how I said when we did infection control, like instead of treating the virus with an antiviral, they treat the virus with an antibacterial, those kind of things. So that could be an issue as well. That could be a factor. Hopefully that isn't, but reality is the reality, okay? So these are some of the systemic factors. Now, with wounds, there are complications associated with wounds, and you need to know those complications, okay? Listed on page 1160. Infection, all right? Wound infection results from the patient's immune system, like it says, okay? Well, further down, you see symptoms of wound infection usually becomes apparent within 7 days after the injury, and often the patient is usually home when they have that infection. And now I want you to note the symptoms associated with a wound infection. Purulent drainage, and we're going to talk about the different characteristics of that drainage in a little bit. Increased drainage, pain, redness, swelling in and around the wound. They can also have increased body temperature and elevated white blood cell count. Important for you to note that. Also, in addition to those mentioned earlier, it could also include, other signs and symptoms include delayed healing and discoloration of granulation tissues in the wound. Okay? So those are some of the characteristics that can tell you that, A, that wound is probably infected. Another complication is hemorrhaging, and it's discussed again on page 1160, where hemorrhage may occur from a slipped suture, for example, dislodged clot at the wound site. Hemorrhaging can also take place as a result of infection, right there, so don't play with me, or erosion of a blood vessel by a foreign body, such as a drain. Again, so what do they mean by a drain? And please don't say the pump, the pipeline, okay? That's not what. When they say drain, what are they talking about?
Like a wound vac?
Like a wound vac, JP, hemovac, okay? Those little, it's a little system, so to speak, where they cut, it's surgically implanted, by the way, that collects basically the liquid that's coming out of the wound bed, okay? And they have the hemovac. And what your job is to make sure you look at around the drain, where the insertion site, where the tubing is, look at the integrity of the skin around the drainage, okay? Now, you see this? Dehiscence versus evisceration. Dehiscence, evisceration. Dehiscence, evisceration. What in the world is dehiscence, Bree? According to the book.
The partial or total separation of wound layers as a result of excessive stress on the wounds that are not healed.
Your wound is separated. The wound was once closed, either surgically or whatnot, and all of a sudden, it is now separated. That is termed dehiscence. What is evisceration, Juliana?
Surgical technique, where intraocular.
Nope. Nope.
Like remove the stuff that's in the needle.
Nope.
Something's out that should be in.
Say it again, please.
Something's out that should be in.
This is a wound complication. Okay, so where your wound is, for example, let's say I had an abdominal surgery. I just had an abdominal surgery. Let me not put this on myself. A client had an abdominal surgery, right? Now, your wound should be intact, nice and clean. That's what we're looking for. But then all of a sudden, the client's gut is spilled out of that wound. That is evisceration. That is a medical emergency. That is something you are not playing with. Be like, oh, your gut is out. Okay, and then keep it moving. No, we are not doing that, okay? It occurs primarily with abdominal incisions, like it says, and look what it says. In evisceration, the abdominal wound completely separates with protrusion of the viscera, internal organs, through what? Okay, all right. Patients who are at greatest risk for this complication are those who are what? Obese, malnourished, who smoking tobacco, using anticoagulants, have an infected wound, experiencing excessive coughing, vomiting, and straining. So if your patient came from surgery, had an abdominal incision, what is your treatment, or what is going to be a part of your plan? Because you see who the risk factors are, right? What are you going to do to prevent evisceration? What do you think?
From coughing.
I don't let them move.
No, they got to move.
Wait, what did you say? If they have what?
If they had an abdominal surgery, right? Of course, there's an abdominal incision. And you see these risk factors, remember, we security guards. What are you going to do or incorporate in your treatment plan or your nursing care plan to prevent evisceration? What could you do?
Because they already have it distance, or they don't have it?
They don't, prevention, they don't have it. They just, huh?
Surgical incision.
You're going to check it, but checking it, you're going to prevent it. Huh? What you said? Give him a pillow. But pillows for my head. What I'm giving him a pillow for?
Pillow to hug.
Pillow to hug.
And then probably also stool softeners.
Stool softeners.
Patient education on movements, on how to get in and out of bed. Without
Yes. What is that called when you give them a pillow to hug? Do we know what that's called? Splinting. You must know this. You are not entering second semester not knowing this, and you better not go into med search like my I forgot. You will not shame me. Okay? Okay? So, like Sophie said, to prevent the evisceration or even the hissing, we're going to encourage the patient to split. So, we remember it says with excessive coughing, and we want the patient to cough and deep breathe, but then we need to be now protective. So, we're going to tell the patient, take your pillow. This is my pillow. Okay? We're going to tell the patient, take your pillow. Whenever you feel the need to cough, whenever you feel the need to sneeze, okay? Because we just said excessive coughing can put the patient at risk for evisceration, and we ain't got time for that because 7:30 we're trying to go home, all right? So listen here, buddy, take your pillow, put it next to your incision. Of course, pillows are soft, okay? And you're going to hug that pillow and cough. Because remember, with coughing, there's that pressure that is exerted on that abdominal area naturally. We're trying to prevent that extra exertion, so we cough, and you hold that pillow as comfortably, tightly as possible, and you cough. You gotta sneeze, okay? You're gonna be sneezing pretty, but hey, we're protecting the evisceration, okay? Now, in the event, because things happen, okay? 7 o'clock is when things usually happen, when you're ready to go, all right? Then organs pop out. Boom. Julietta, what you gonna do?
That's not good.
It's not good. We know that ain't good, but what we gonna do?
Push it back in. Cold blue.
No, you can't push it back. You definitely calling code blue, but before you call anybody, what do you do?
Cover it with a sterile towel.
Say it again. Cover with a sterile towel. If you have an evisceration, the gut is out of the wound, okay, then, or the internal organs are out, you can't just look at that patient and call code blue, okay? Before you call code blue, you are not leaving that patient, number one. You are staying with the patient, and you calling whomever. Hey, first of all, as a great nurse, because the patient had an abdominal incision, you're going to make sure you have these equipment at bedside anyway, preventative, to prepare for the worst. Because it can happen at any time, and it's going to happen during change of shift when you're ready to go, okay? Warning, all right? Spoiler alert, all right? Now, in the event it does happen, you can't just leave the patient. You may have to have someone else call that code blue, because your priority is to protect the patient now. So you stay with the patient, put in a sterile towel, okay, because sterile towel with sterile normal saline, you're gonna have, well, you ain't gonna have time.
I was gonna ask, does it have to be a wet dressing or can it be dry?
No, it can't be dry. It has to be wet.
That's what I thought.
It cannot be wet. It cannot be dry.
You can't just throw
No.
a towel on there.
No, yeah, you have to have all these stuff already at bedside. It's gonna be dry in a package now, okay, but
So like with like normal saline?
yes. Okay, 0, and it has to be all sterile, because remember, this is a wound site. Okay, especially an incision, right? And you're staying with the patient. If you can reach for the code blue button, go on ahead. But knowing most facility, that code blue button is really on the opposite side of the bed, and the bed is right here. So either you call somebody else to tell them to call code blue or whatnot, but it is now a medical emergency, and they got to go down to OR like yesteryear.
You do the same with the stoma, right? When you're changing the hospital.
You're gonna have to explain to me with the sterile towel.
One time a patient, it came off.
The stoma came off?
No, the colostomy bag from the stoma, like the skin.
That's not. You just changed the bag.
I know, but like.
But you don't need that. You are not calling a code blue.
No, I'm not saying.
Okay, so what do you mean? Do
Just cover the stoma with a wet towel.
It don't. No, it don't. The stoma is different. It doesn't have to be a wet towel. First of all, the stoma doesn't even need to be covered. Right. Hold on. Stoma is different. If the patient is having loose stools, to protect the patient and the clothing, and the linen, yeah, you can put a towel, but you can't even apply pressure. The towel is not even going to do much, to be honest. okay? It's just so if a little squirt come out, you know, you protecting the linen as much as possible. It's not a medical emergency. You just go on ahead and change the kit. Sometimes you may not even change the own kit. Sometimes it's just a bag you need to change, okay? Depending on what's soiled or what's discombobulated at that point, okay? But it's completely different because this is now the internal organs that popped out, and your organs needs to be inside your body, and now it's outside your body, okay? And that ain't cool. And Juliana is not gonna be like, oh, that ain't good. Juliana gonna be doing more than that. She's gonna make sure she has everything. And also because of that, in addition to now it's gonna be different according to different facilities. Sometimes they might have you're gonna have to make sure that the crash cart is available, airway, like the cannula, oxygen, and all that stuff is gonna be important. But it's most important to have that sterile towel, sterile solutions just in case that does happen, okay? Alrighty, moving forward. All right, yes. Oh,
Well,
Juliana.
it also says that you like put the patient in low Fowler.
Oh, thank you, the position. Say it again, what position you have to be in?
Low Fowler.
Low Fowler's position. Now, why does the patient have to be in low Fowler's position?
That's like decrease like the pressure.
The pressure, okay? Thank you for bringing that up. Yes, very important, okay? So that's dehiscence and evisceration. Our goal is to prevent it at all costs. And the other complication, potential complication, is a fistula, all right? Now, a fistula, notice what it says on page 1161, is an abnormal passage from the internal organ or vessel to the outside of the body, or from one internal organ or vessel to another.
Not a hernia.
It's a-
Now, wait, what?
What about a hernia?
What about a hernia?
Because that could come out through the abdominal wall.
It's not considered a fistula.
No,
No, not a fistula, but I'm just saying, what about just a hernia?
that's not a complication. A hernia is not going to be a complication of the wound. That's just something completely different.
Okay.
Okay. For example, hernias can happen like you have a herniated disc, for example, or
An abdominal hernia, where it's obtruding out.
She's talking about when there's a tear and there's compromise in the muscle
Like
or
it's
something.
in
yeah, but it doesn't. That's not a common complication from the wound.
No, it's not.
No, it's completely different.
Okay.
Yeah. Okay. What else? However, now the thing is with the fistula, remember, generally speaking, it's an abnormal formation, right? However, a fistula can actually be formed on purpose, and that's the AV fistula for dialysis, okay, which we already talked about. All right. We already did the pressure injury, fistula formation. We talked about the evisceration and dehiscence. Okay. Factors affecting pressure injury, of course, aging, chronic illness, immobility, all this stuff we already talked about. Neuromuscular disorders, spinal cord injuries, etc. All right. Mechanisms and pressure injury development. So external pressure compressing the blood vessels, friction and shearing. This right here, friction and shearing, is something you have to make sure you are cognizant and aware of. It's one thing that you definitely want to prevent. What? Okay, thank you for the answer. I was just about to ask, what the heck is friction? What is it?
It occurs when two surfaces rub against each other.
All right, and what is shearing?
Shearing results when one layer of tissue slides over another.
When one layer of tissue, and both of them, now how can it be prevented? How can we prevent friction? We already know we don't want it, but how can we prevent it? You have no idea?
Pillows? Can we put like pillows?
Okay, you're gonna have to explain that. You might be onto something. I'm trying to understand.
Because if they're just laying like flat on the bed, like they're prone to like moving around and then rubbing. But if you put a pillow, it's a little bit more softer than the hard surface.
And the mattress is soft too?
It says patients that are partially seated up in bed are more susceptible to shearing forces. So maybe lay them down flatter and not have them sitting up like at an angle that puts more force.
Position. So in other words, you see like how on page 1163 that lady is sitting? So as she goes, she might have the tension to slide down, and then the linen is gonna go the opposite. You understand? One way you could prevent it is, well, not prevent it, but one thing you can do to help with that, let's say we have to move the patient up in bed. So instead of just moving the patient just like that with their body, we're going to take a friction reducing sheet and then slide the patient up or glide the patient up in bed. Remember that friction sheet I showed y'all when we did mobility? Y'all don't remember the blue sheet? Huh?
It says to lift them completely rather than like pull them.
You are not gonna lift anybody.
That's what it says.
No, when you with the sheet though, you're not gonna pull them. In other words, you're my client. In other words, you're not gonna pull them up. Okay? I gotta make sure she's up. Okay? But you're gonna put a sheet underneath her. If you do have access to a friction reducing sheet, that's even better. But if you just have the linen, then just use the linen. It's better than nothing. Does that make sense? So you pull the patient up with the sheet instead of pulling them up, with their arm or something like that. All right? What else? Okay. Okay, we already know the risk factor for pressure injury, inadequate nutrition, immobility, mental status, and age. We already talked about the stages of pressure injuries, the physiologic effects of the wound. We do know that the wounds can be painful. So if you're gonna have to do a wound dressing, what are you gonna do prior to your wound dressing? So
Get my supplies.
okay, yeah, you're gonna gather your supplies. All right, what you gonna do first? Really? Why?
Because it's gonna be painful as all get out to clean it out, so you wanna make sure that's gonna.
Thank you. So you assess. You're going to assess first of all, is the patient even in pain? You do need to assess for allergies as well, because if they're allergic to iodine, you can't be using iodine to treat the wound. You understand? So you're going to do your assessment. And if the patient is in pain, you are not doing that wound dressing until you have managed the pain. All right? Now, you already did medications already. You should very well be familiar with the fact review that IV medications work faster than oral medications. However, oral medication lasts longer than intravenous medications. Do not play with me. Comprende? So, with that said, since you was going to do pain management, Crystal, you gave your patient has a stage 4 pressure injury in the sacral area. As the great fantabulous nurse that you are, you went to assess for pain. Patient told you that their pain is 9 out of 10. And you're like, I got something for you. Let me hook you up. You go and hook the patient up with some Percocet, which is an oral pain medication. What time, give or take, you will come back to check up on the patient to see if you could do your wound dressing?
When was the last time they ate?
Huh?
When was the last time they ate?
When was the last time they ate?
A meal. When was the last time they ate?
The scenario didn't give you that.
Probably about an hour.
Thank you. See, that's what I need you to be worried about. Only worry about what's in the scenario, not us. Thank you very much. Come about an hour, because it might take an hour for it to work. But you had another patient who had a stage 3. I don't know why I'm giving you the wound patients, but I'm just giving them to you, okay? And then this one, had an unstageable. And they tell you their pain level is 20 out of 10. You said no problem. I'm gonna hook you up. You gave them dilaudid 2 milligram IV. What time you coming back to check up on them?
5 minutes.
Give or take, maybe 15, no more. But yes, because it works faster. You see what I just did there? You see how you did that nicely?
Maybe you just need to read the questions. I'm not joking.
Look at you, straight to the point.
I gotta go get your accommodation.
Okay, so you should know, depending on what type of medication you gave them, when you should go back, give or take, to check up on the person. Okay, so you can actually do the dressing change, because if they are in pain, you cannot really do that wound dressing. All right. Other physiologic factors include anxiety. If I'm anxious, okay, Alana, you went to go in and do your your wound care on a client who has like maybe a stage 2. Okay. And the patient is over the top anxious. Like, I'm like, you know what? Not even a stage 2, bruh. It was really a stage 1. Okay. And they are over the top anxious. What you gonna do with that, Alana? And you need to tend to that wound, because you are a great nurse. You got to go home, but before you go home, you want to make sure all your patients are well taken care of. You know what I mean? But your patient got a stage 1, and you need to attend to that. They're over the top anxious. What are you gonna do?
Try to calm them down.
Oh,
Go
okay.
through the procedure.
Okay, all right. How would you calm them down?
Therapeutic communication.
Okay, therapeutic communication. Okay, I like it. Talk to me. What is therapeutic? Because what may be therapeutic for you may not be therapeutic for me. I gotta need to make sure you know what because you look like your therapeutic may not be that therapeutic. What's therapeutic? What you going? I'm anxious. Oh my God! You gotta do my way just to change. Oh my God! What's that therapeutic? Look, Crystal said, "Look, I ain't got time for no therapeutic at that point. Valium right away." What you gonna do?
Holding their hand.
You go.
Asking them what they're.
Look at giving the nice NCLEX answers that she know in real life. She ain't gonna do none of that. Hold their hand. Okay, you go hold my hand, calm me down, be like, listen, it's just a stage 1. Take a breather. It's not well, you can't say it's not that serious.
Very therapeutic.
I bet that's how y'all reading these questions though. Okay? Okay? Do not read the questions like in your mind. I don't know. Okay, that did not make sense, but whatever. Therapeutic, start least invasive, calm them down. Do not be so quick to medicate them. I know, not in Crystal's land. You getting that verse said right away, just for stage 2. Okay? All right, so you deal with the anxiety, therapeutic, or you could do guided imagery too, or whatever, just to music, all that stuff, all right? Address their fears. Again, just like what Alana said, I'm going to communicate with you therapeutically, all right? Other factors is impact of activities of daily living. Some people, again, seriously speaking though, there are some people, they were very active, and then once they got this particular wound, whether it be like a severe fracture, maybe, or a motor vehicle accident or something like that, now their activities of daily living has declined. They were once independent, now they are dependent. That could affect that individual psychologically as well, and decline how much they can do independently. Another thing you're going to have to assess is the change in body image. That's a big deal. Okay. There are people that does take their image like very, very seriously. And if I had a wound to my face, like somebody cut me, or I ended up with a cut to my face, my beautiful, good looking face. Y'all see this beauty here? And then all of a sudden I have a cut. How is that going to affect me? And one of the ways it can affect me is psychologically. You understand? And you as a great nurse have to address that. Okay? All right, health history, you already know all of this. Now, with regards to elimination, I talked about it a little bit before. And let's say if the patient does have a wound in the sacral or perineal area, specifically, let's say in the perineal area, now, I'm not giving y'all an answer. Let me see if y'all remember. If they have a wound, stage 3 wound in the perineal, in the perineal area, you did your assessment, took care of your patient, pain-wise, did what you had to do, but they have urinary incontinence. Okay. What are some recommendations, or what do you want to do with that? Patient has a stage 3 perineal area. What may you want to consider to protect that wound affected area? But they're incontinent. Are you going to always catch it? They're incontinent. Stage 3 wound, perineal area. What may you want to recommend or consider? Incontinent of urine.
That's urine?
Just urine. Let's keep it simple for now. Why would you want to do a straight cath? You said straight cath. Why would you want to?
Protect the integrity, so that
Okay, when would you do the straight cath then?
when?
Mm-hmm.
You only use a straight cath when they are like holding on to the
Yeah.
fluids.
Oh, Nathan. So then, what would you consider instead? No, they already got a wound. I just did I not say the stage? What stage did I say? Stage 3.
What's that cream and powder they mix together to put?
A Foley.
You may want to consider a Foley.
I thought you said
Or last
Well,
resort.
she does it completely.
I said, you see, they are completely incontinent of urine.
But we don't make that decision.
That's why you do what? You make a recommendation. Part of your SBAR. You see what I did there? You see what I did there? That's part of critical thinking. Okay, critical thinking, communication, clinical judgment, all that. You understand? Yes, Foley catheter, generally speaking, is your last resort. However, now this patient is incontinent, completely incontinent of urine, and you have a stage 3 perineal wound. And you know urine is going to make that wound even worse. Is that what?
Like, when would you really consider using a Foley? Because I know they don't.
That's an
A
example.
last resort, like it would be.
Like a wound.
possibly a 3
Yes. Now, if they're constantly retaining, even after straight cathing, for example, they still continue to retain, for example, the physician may want a Foley catheter.
Well, I mean, like, by your example, you would, like, if there's a test question, for example.
Here we go. Not her trying to get the answers to my test. You see what she's trying to do right there? She's trying to get the answers to my test.
Are you gonna, is that the answer, or you just want, like, stage 3 is stage 3?
Okay.
That's where I'm gonna be like,
Juliana,
when do
help
you
a sister out.
exactly want a Foley?
Juliana.
About the wound to the perineal area. She said when the catheter is the last resort, but
Right.
one instance in which you would use it is if there's a wound to the perineal
So any
area. So I think if it was a
Okay.
wound, period,
Okay,
in that area, and they
I'm
were
about to
completely
get that
incontinent
wrong.
of urine, it would be Foley catheter.
okay.
Correct?
Do we comprende? Do we comprende?
Yes.
Yes. Okay. All right.
Because I know that if they're not just
They gotta be completely incontinent. You do measure seriously speaking, you wanna measure the risk versus the benefit. If they're completely incontinent, that wound is getting worse, progressively worse. And we know the urine is only gonna make matters even worse for that wound healing to take place. In other words, it's not going to take place actually. So yes, we may want to ask the doctor, can we insert a Foley catheter? Because we tried. Now remember, this is your last resort, right? If you can try to safely try other methods, but let's say I know I pronounced the word all this wrong. The Pyrex may not be how you pronounce Pyrrhic. I don't know why I always call it Pyrex. I don't know. Don't judge me. You know, I'm just a girl. You know. All right. The Pyrrhic may not be feasible. because it may actually jeopardize it even more, because depending on, let's say, all that growing area, the labia, all the way down to the thigh is all raw. You understand? You may want to consider a Foley. You may want to consider. I never, you see what they just did me? That, I feel like that's wrong. I never trick my students on the exam. They just need to read the question carefully. It ain't my fault y'all ain't read like I told y'all to read. But hey, who's getting to blame? Me again. Let's keep it moving. All right, elimination. All right, boom, boom, boom. Skin assessment. Again, the least invasive assessment that you're going to do is inspect, where you're just looking at the person. Remember, that's always least invasive. That's the first thing you're going to do. Look at it. And then you're going to palpate. And you already know how to palpate, you know, assessing for temperature and stuff like that. Your assessment is going to include, as needed, again, it may be a full head to toe assessment. Now, sometimes you may need to just do a focus assessment. Sometimes you may just need, focus assessment. I was going to say emergent. I don't know about emergent. Well, it can be emergent, actually. If the patient fell, for example, and they had a concussion, you might need to do a emergent. Your skin assessment is also going to include, but is not limited to, the bony prominences. You definitely are looking at the bony prominent area, for example, your hip, the elbows, etc., right? But it's not limited to just that. I don't know if I told y'all the story when I had an elderly patient who came from a nursing home of sorts. It's like he was the king of wounds from head to toe, unfortunately. From head to toe, ears was raw, chin was raw, neck was raw. I was like, this person was neglected. Okay, so again, it's not limited to the bony prominences. Now, you also do your admission. Let me tell y'all something. I don't care how busy y'all is. Okay, your admission assessment must include a full head to toe skin assessment. Because let me tell y'all, from experience, not to me, but what happened was one of my co-workers got floated to another unit. Well, you know, we all hate being floated to another unit, but it is what it is. And of course, when we get floated, we get the worst patients, but she was given one of the worst patients, which was a morbidly obese client who was about 750 pounds. Okay? She did not do the admission, but this was a patient that she ended up having. This probably, by the time she had the patient, it's probably his, third or fourth day there. Long story short, she gets called to the office, okay, because no one documented that they did a skin assessment on this person. No one did a skin assessment on this patient, especially in the sacral area. By the time they were able to turn this client, he had a huge sacral stage 4 wound. And guess what he said? It happened here. And the patient was only there 3-4 days. But there's no proof. You see that? This is why on admission, you should, as much as possible, do a full head to toe skin assessment to see if the skin is intact or not. All right? So skin assessment is done on admission and at regular intervals as necessary. So if the patient's skin is intact, you may just need to do a skin assessment only once a shift, okay, on your first encounter with the client on that shift. But also, it may need to be done as needed, PRN, depending on what happened. Let's say during your shift, that's when the patient happened to fall. That's what we're trying to avoid. But then on your fall, that's when they developed a cut or a wound of some sort. So you're now doing your wound assessment, or your skin assessment rather, as more frequently. In acute settings, like a hospital, it's done every shift. Again, depending on the situation. Long-term settings, like an ALF, for example, or LTAC, maybe. Well, it depends. LTAC can be acute too. But long-term settings, usually they can do it weekly for 4 weeks, then quarterly. Okay? But in a home health setting, it's done with each visit. So pay attention to the setting. Okay? Don't play with me. Moving forward. Your wound assessment is going to include the appearance, where you're going to know the size, the depth, the presence of any undermining, any tunneling, like we saw with this client here that's tunneling, or if there's any sinus tract. What the heck is a sinus tract? Ugh, that sounds like in your nose. Sinus. Ugh. What is sinus tract? I don't know what that is. Nate, hurry up. Yeah, no, I don't know what that is. You have a laptop. What? TikTok. I'm gonna need for my students to. I'm gonna need for my students to know how to cheat better. I mean.
Potential for infection.
Say it again.
A cavity or channel underneath the wound that has potential for infection.
A cavity or a wound which has a potential. So plain English, because you know I'm the 2-year-old that just got off the boat the other day. What does that mean?
So it's splunking trick.
Huh?
The bacteria.
Wait, what you said? Wait, it's what?
I said the bacteria goes on a splunking trip.
Splunking?
It's go through these really tiny tunnels to get to a big cave.
You don't know what spelunking?
I have never heard of splunking.
Oh, okay.
But there's like specific
Then it's
diseases
lost
for
on
that.
you. But anyway, it's the same.
You know I'm not gonna forget now splunking.
Yeah, it's where they go like.
That's how they get the
I ain't never heard of splunking in my life.
histoplasmosis. That's where they usually get it from. Yeah.
Oh, okay. So basically, what is a sinus tract?
Like after an incision and like drainage of
Splunking.
and abdominal surgery. It's like a way for an open drainage system.
It's okay. All right. Do we all understand? So any of this that you see, you have to assess. Okay. You're also looking at the drainage. You see here? Don't play with me with these words. The drainage. Is it serous? And where my Latinos at? In Spanish? Very fluent? Okay. Listen. I'm sorry. Sanguineous. ¿Qué es eso?
I've never heard that word. Me neither.
Bloody.
Okay.
Sangre?
Yes.
That's not what you
No, but it kind of have it.
Yeah.
You see it?
Oh.
That's what I'm trying to make you do. You see? Sung, hello. Okay, you see you?
Sunday is blood.
Oh, it's just you two?
No, it's her.
Oh, and you? Don't play with me. Okay, look. Huh?
Not too much.
Look at her trying to highlight. Okay. Now, do we know what serous is?
Us.
Yes, but it's like there's no blood. It's not bloody.
No.
Not pus. Oh yeah, that's true. It's not pus. What is serous?
Just like clear.
Clear. Okay. Thank you very much. Now, if you have serous sanguineous, it's both. Okay. This is all what? This is all what? The sanguineous. All what? Bloody. And this is now, and maybe pinkish, okay? Because you got red and white makes pink, okay? And then purulent is, that's the pussy. Ooh, the pus.
You weren't wrong. I think if you wouldn't have stopped, then we would have continued. We got okay.
Okay, I have to make sure I exit that, oh Lord.
You said
Okay, y'all get the point, all right? Oh my God, I'm in trouble. All right, boom. Preventing pressure injuries. Again, our goal is preventative measures as much as possible. Assess patients who are at risk daily. Cleanse the skin routinely. Now, when you're cleansing the skin routinely, especially those who have fragile skin, you want to make sure you cleanse it carefully, right? You're not using vigorous force, all right? Or also with regards to cleansing, those who are prone or at risk for DVTs from prolonged immobility, you're also being careful, okay, with how you cleanse it, not being vigorous. Or if they even have a DVT, that site still needs to be cleansed, but now you're just going to be lightly tapping. Yes, Chelsea?
I get really confused when it comes up in a question when it says like wash the skin daily, but then there's other questions that said don't wash the skin daily because you're gonna compromise the integrity of the skin. So it's like, which one do I do?
Which one said what? Show me where it says wash the skin daily, because I know where
There's
we.
like in prep,
No.
there's some questions where it said like for like the foot or something like that. It'll say like make sure
You
you
should-
clean it with warm water daily.
You sure it doesn't say assess the site daily?
No, it says clean it with warm water daily. But then I didn't choose that one because I know if you clean it with warm water daily, you're gonna compromise the skin.
If this is in prep you?
Yeah.
Okay, I have to see that
So
question.
which one do you do though?
No. So I have to be careful with this. You have to do it routinely. Now, first of all, there's a matter of culture. Certain cultures, they do bathe more than once daily. So there is the issue of client preference, right? If there is not a contraindication where the skin, like for example, there's that risk of, or they have a DVT or something like that, there's no contraindications, you bathe or cleanse that skin, the client's skin, or you allow them to bathe daily or even more frequently depending on the client's skin. Because there are people who bathe, 2 or 3 times a day, especially when it's summertime. However, if the client does have health issues, okay, diabetic neuropathy, wound, incontinence is not an issue of daily now, it's going to be as needed. Because if you're incontinent, you actually have to cleanse, you may have to cleanse more frequently because you can't leave the patient sitting there in urine frequently. It's just a matter of how you're cleansing, what you're cleansing with. You're not going to use those rough newspaper-like towels because it's going to further compromise the towel. And so instead of using those towels, those little towels, you might use those wipes instead because it's friendlier to the skin. Does that make sense? Now with the foot that you mentioned, I would like to see that question to see what they're talking about. But if it's like a diabetic neuropathy patient, you do have to assess, and sometimes even more frequently than daily, especially if they have extreme neuropathy. But I got to see that question. Okay. If you find the question, send it to me. All right. What else? Protect the skin from moisture. So you want to make sure you pat dry. Minimize skin injury from friction or shearing, which we already talked about. Proper positioning, turning. Remember, if the patient has limited mobility or if they are immobile completely, we are turning them every 2 hours or more frequently as necessary. Now, there are some clients, let's say for whatever reason, there are some clients who cannot be moved as much, maybe because of a surgical intervention or maybe because of some hemodynamic issue. So instead, we're going to put these clients on a special bed that can turn for them. Yes. Crystal, why are you looking at me like that for? Crystal, you're confusing me.
No, I had a question. What are the beds? So at clinicals, the patient I had last week was a new amputee, and he had a special. It wasn't a bed that like turns and stuff like that. He also had.
Was it like a water bed, almost like an airflow bed? Yeah. Yeah, because if he's prone. Yeah, they have pressure. I forgot the exact name. That's what they call it?
That's what we call it.
Oh, okay. I don't know, that's new for me, but hey. So it's just air in like an air mattress. You know how like the remember back in the day water beds? Yeah. Okay, I know I'm dead. You found it? Okay, hold on to it.
Turns them.
Yes.
But you still have to turn them.
But you can actually program the bed to turn every so often.
They still make that turn.
So in other words, so what it really doing is not actually turning like it's just actually relieving pressure from one side over another.
Okay, I was doing that.
Yeah, that's what they're doing. But
And he was starting to get shear injuries on his elbows because for him to reposition himself, because he has pretty much no use of the leg that is still there right now. Healing and spinal injury and stuff like that. And then the right side is a new amputee, so he was he uses his elbows a lot, so they put bandages
To protect his elbow?
to protect his skin from
Oh, okay, yeah.
because otherwise he has no other way to.
And you know what they, instead of the, what did you say they use?
They're just big bandages.
Bands? You know what they could have used too? Memolex.
Yeah.
Yeah.
That's what
That's what they should have used. And I'm gonna show you tomorrow. So Memolex is basically like a second skin. It's actually friendlier.
and they're like
Super
Yes.
That's what it was.
Oh, okay.
Big, but they were big giant ones.
Yes, it looked like a second skin.
Yeah.
Yeah.
Yeah, it
That's,
was the same color. The same color as the Band-Aid, but it was like a.
they're usually pinkish. Yeah, I have them downstairs. Well, I'm supposed to have them downstairs if they didn't use it. Mepilex. Yeah, Mepilex. That's preferred over just bandages. Okay. So turning frequently and transferring appropriate support surfaces, nutritional supplement as necessary. If the patient doesn't need it, then we don't need to give it to them, okay? And improve mobility and activity. So these are some of the things that we can do to prevent injury. Now, make sure you know your dressings. Wait a minute. Where's the page that talks about the, yeah, right here. On page 1182. It is at this point now, they're not gonna call me the cool teacher anymore. I don't know if they already stopped calling me the cool teacher, but I'm requiring that they know a whole 2 pages of boxes. And yeah, they're going to be mad at me, but it is what it is, such is life.
That's a lot of bandages.
Huh?
Our next test at 1:30.
It says 11:35.
That's an hour.
Oh my gosh! I was thinking I had time.
I was holding up the watch.
Okay, that meant nothing to me. Okay, guys, class is dismissed. I didn't realize I overtook their lunchtime. Okay, we'll finish this tomorrow. Oh man, my bad. I was getting all into this. Ah, damn, then I missed my appointment. I hope. Goodbye, guys. It's been real. And now.